Nausea and vomiting in pregnancy, the famous morning sickness. This is often how nausea and vomiting in pregnancy is referred to colloquially. Unlike the name, it can actually occur at any time of day. And it is very common, affecting 80% of pregnant women, and it is the most common indication for a hospital admission during pregnancy. It is diagnosed in the first trimester of pregnancy, when other causes of nausea and vomiting have been excluded. It is thought to be related to high beta-HCG levels in pregnancy. In fact, nausea and vomiting tends to be more pronounced in situations with higher HCG levels, such as multiple pregnancy and molar pregnancy. You might have also heard of hyperemesis gravidarum. This refers to a severe form of nausea and vomiting in pregnancy, occurring in 0.3 to 3.6% of pregnant women. It is diagnosed when a woman has excessive nausea and vomiting associated with weight loss of more than 5% of her pre-pregnancy weight, dehydration, and electrolyte imbalance. We'll be going into the specifics of these a bit later on. Now, nausea and vomiting in pregnancy is classified according to the PUC score. PUC actually stands for Pregnancy Unique Quantification of Emesis. Essentially, nausea and vomiting is classified as being either mild, moderate, or severe, and this is done by asking 3 questions. In the last 24 hours, how long have you felt nauseated or sick to your stomach? In the last 24 hours, how long have you vomited or thrown up? In the last 24 hours, how many times have you had retching or dry heaves without bringing anything up? A scoring system is used for each of these questions. Then they are added up, leaving you with the final classification of mild, moderate, or severe nausea and vomiting. Nausea and vomiting in pregnancy is, as we said, a very common presentation to our emergency rooms or early pregnancy units. During these assessments, of course, we start off with a history, asking for any previous history of nausea and vomiting or hyperemesis in this or a previous pregnancy. We want to quantify the symptoms using the PUC score we just mentioned and asking some specific questions like how many episodes of vomiting did she have, any weight loss, if she's able to tolerate food and fluids, and the effect on her quality of life. Is this limiting her from going to work or caring for her children? We also want to exclude other causes, so we inquire for some other symptoms like abdominal pain, urinary symptoms, fever, maybe she has a history of a chronic Helicobacter pylori infection. We also want to know what drugs she's currently taking, for example any anti-emetics or PPIs she might already be on. Of course, we also want to examine her, so we want to check her full parameters as part of a standard routine assessment. We want to perform an abdominal examination and assess for any tenderness. Perhaps she has epigastric tenderness from the multiple vomiting episodes. We also want to assess her weight to check for any sudden weight loss. Look for signs of dehydration and possibly muscle wasting in severe cases. Next up, we have the investigations. We definitely want to perform a urine dipstick and check for any signs of ketonuria, signifying a degree of dehydration. Sometimes symptoms and signs of a urinary tract infection may necessitate a midstream urine sample to be sent to the lab for culture and sensitivity. We can also perform some blood tests, including urea and electrolytes, once again to assess for dehydration and any electrolyte imbalances that may occur. So as a side note here, in patients who are profusely vomiting, they are flushing out potassium ions, hydrogen and chloride ions. Therefore, we need to keep an eye out for hypokalemia, a metabolic acidosis, and hypochloremia. Most of the time, we are most concerned with our potassium levels. Therefore, these must be checked and corrected if need be. We can also take a complete blood count, possibly assessing for any signs of infection or anemia, and a glucose level to exclude diabetic ketoacidosis in known diabetics. We also perform an ultrasound scan to confirm viability of the pregnancy and also exclude a multiple or molar pregnancy, which, as we stated before, might be the cause of her excessive vomiting. Now, in refractory cases or in women with previous admissions, we should also be checking her TFTs. TSH has a similar configuration to HCG and may be playing a role. LFTs, we want to exclude other causes such as hepatitis or gallstones and also monitor malnutrition. Calcium and phosphate, an amylase to exclude pancreatitis, and ABGs, as we said before, to monitor for possible metabolic acidosis. Now, when we are dealing with nausea and vomiting in pregnancy, we obviously have to keep in mind that this may be coming from another cause. So here we're going to be looking at the differential diagnoses, including a peptic ulcer, chronic Helicobacter pylori infection, cholecystitis, gastroenteritis, genitourinary causes such as a UTI or pyelonephritis, metabolic causes, neurological, or drug-induced nausea and vomiting. Okay, so now let's have a look at the management. So essentially we have three main domains we need to keep in mind. Number 1, anti-emetics. Number 2, rehydration. Number 3, other inpatient support. Now before we delve into these, let's first think about which of these patients will actually need inpatient management, because not all of them need to be admitted to hospital, of course. So admission is required if they are unable to keep oral antiemetics down, if they have ketonuria or possible associated weight loss, or if they have a comorbidity such as a UTI causing the nausea and vomiting. Okay, so back to our domain. So of course, antiemetics are part of the mainstay of treatment. There are different antiemetics that we use, which of course are safe in pregnancy. First line, we use cyclizine. Second line, metoclopramide or ondansetron. And third line, hydrocortisone. If the nausea and vomiting is severe enough, we can use a combination of these and can also administer them as an IV preparation during hospital admission. Next up, we need to ensure adequate hydration. So we can encourage patients to ensure they are pushing oral fluids, or if not tolerating and therefore admitted, we can give them an IVI drip containing normal saline and being topped up with KCl depending on her electrolytes on regular bloods. Next, we've got some other support we offer those patients who are admitted. So we've got a PPI such as omeprazole, as usually patients with severe nausea and vomiting are also suffering from burning epigastric pain, which we call heartburn. We also provide thiamine supplementation. So a side note here, why do we do this? Essentially to prevent wernicke's encephalopathy, which occurs due to vitamin B1 or thiamine deficiency. This is rare, but patients present with blurred vision, unsteadiness, confusion, nystagmus, ophthalmoplegia, hyporeflexia or areflexia, and gait or finger-nose ataxia. So it's something to keep in mind. We also offer these patients thromboprophylaxis due to the increased risk of developing a DVT or PE. So that pretty much sums up our discussion on nausea and vomiting in pregnancy. I hope this video was helpful. Like and subscribe.